Hey class, welcome to Diabetes, Chapter 46. Diabetes is going to be one of the premier things you're going to deal with as a nurse in hospital, clinic, in life. You're going to come across this a lot. It's increasing in the uh, amount of uh, prevalence among all populations. Okay, so what is diabetes? Diabetes is the it's the body's inability to process sugar, okay? Mismanagement of the insulin and how it works and how it affects things. There's a lot involved in this. Um, so I want to draw attention to that last bullet, okay? Why would ethnic and racial minorities be disproportionately affected? Okay, well, this comes down into the fact that diabetes is directly related to the amount of obesity in today's society. So childhood obesity going into this, we have biological effects, and these effects turn around and bring on this type 2 diabetes. I want you to know that that this diabetes is genetic, but it's also acquired. Okay, so let's talk about the types. We have type 1 diabetes, also referred to as juvenile diabetes. It is an autoimmune um, uh, effect on the body. Okay, the body eating the beta cells within the um, within the pancreas and decreasing the amount of insulin that can be produced. Okay, these are going to be your insulin dependent diabetics. Then we have our type 2 diabetes, which is our diabetes related to late onset due to obesity, due to trauma, damage to the pancreas, drinking, drug use, um, genetics in general, just when you hit a marker that can set you off on that. Then you have your pregnancy issues just with gestational diabetes. That's why those of you who've had kids, they do that sugar test. That is another a whole that is another realm, but we'll talk a little bit about that as well. Um, Pre-diabetes, no such thing. Okay, I mean, yes, there is a thing, but if you are told you are something that has the word diabetes in it, you have diabetes. This is just a point of which they say, hey, you are potentially going to be a type 2 diabetic. You have time to change your life. Make some changes, okay? Walk around the block. Eat a salad once in a while. Try to do some weight. Do something to affect your outcome. But most people will read pre-diabetes as I don't have it yet, so let me enjoy one more ice cream cone. Okay, so this LADA, late autoimmune diabetes of adults, this is also your diabetes type 1.5. All right, so diabetes 1.5, this is your late onset type 1 diabetes. In other words, you were autoimmune, okay, from childhood, you still were, okay, um, but the rate that your body was destroying the beta cells was very slow. So therefore, you didn't succumb to diabetes until your mid 20s, late 30s, sometimes early 40s. Okay, and then this person is probably going to be treated as a type 2 diabetic until they realize that they can't be handled with oral medications, diet, and exercise, and then they start reevaluating and determine that they are a late onset of type 1 diabetes. Okay. Um, it's also associated with those syndromes and things that I mentioned earlier. There is a new type 3 diabetes that is I was just made aware of And the research is out there in the notes on these slides when I post them. There is a link to NIH.gov regarding type 3 diabetes. This is a insulin resistance in the brain that they are working on. They found a tie to Alzheimer's and dementia. So they are working about that, and I was telling some of the guys I'm in class with, and one of them goes, "I think there was a Grey's Anatomy episode with that, and talk about, oh, don't publish that, you're crazy," but it's an actual thing. Okay. So our functions, function of insulin, it it turns around and it is the gatekeeper. It opens the cell door to allow glucose to go into the cell for use or transfer into storage later. So it says, hey, you know what? I don't need you right now for energy. Let's turn around and open that door to the fat cell and let you in there, and the fat cell gets a little bit bigger. All right. And then it also helps with that amino acids and things of that nature as well. So when you start dealing with amino acids and energy delivery, you can start to imagine the work on affecting the your metabolism, your vasculature, just the nerves, feeding those nerves, getting that. Think about the use of sugar and its effect. The brain is the only thing that runs off of sugar. So if you're not maintaining that, your altermentations, your nervous system is going to be directly affected. And therefore, if you affect the brain and the nervous system, you can affect everything in the body. So therefore, diabetes is a tie-in and an increase in most major comorbidities. All right. So I've already kind of covered this. So that type 1 diabetes being that autoimmune, where the beta cells in the pancreas are being destroyed. It states environmental factors, but it's mostly that genetic autoimmune dysfunction of the body. All right, very low percent. This is your 5 to 10% of your diabetic patients, including one of you in class, right? Okay. So this can be very, very effective. All right, now type 2. This is an impaired insulin secretion or insulin resistance of the cell to turn around and fight against that. So there's been a lot of commercials, take this if you have insulin resistant fat, blah, 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 blah. We might have the answer for you. And then they want to try and get you to jump on some fad diet. Okay, but this is your 90 to 95% of all your diabetes. Now, these numbers might be skewed a little bit because you have that late onset, and those are initially diagnosed as type 2s. So I don't know how accurate those numbers are regarding type 1 and type 2. All right. And this is your type 2, these are people who can help their diabetes. They can reduce the effect of diabetes on their body. Diet, exercise, watching those carbs, just being educated about it. They can reduce themselves down to next to nothing just on the diet and oral anti-diabetic medications like metformin and your semaglutide, like the Ozempics and things of that nature, sulfonylureas. And I have a whole long list that I'm going to briefly cover on the following slides regarding oral medications and treatments. In some cases, in a lot of cases, if you are a type 2 diabetic and you're in the hospital, they are going to check you and manage you with insulin, even if that patient doesn't use insulin outside the hospital, because it's something that we can control. All right. And then here's all those insulins, you might want to pay attention to metformin because in the US it actually is sold by a different name. Also, biguanide. So you pay attention to that. You might see that again. And then we have our other meds. Might see some that look familiar to you here, like Genevia, Tradjenta. As far as your DPP4 inhibitors, they work to improve that that A1C. Of course, all these medications turn around and have an effect on weight. So some of them are used off market label for obesity, weight control. So just because you see these medications on a patient's MAR, make sure that they are actually diabetic. It could be an imperative thing because a doctor might see it on the MAR and go, oh, they're diabetic based on these medications, and it was actually just given for weight control. Here's our other ones, our GLP-1s, and our favorites like Ozempic and Trulicity. Okay, so Rybelsus, things of that nature, so injectables. These are also used and well known for their use as weight control as well as diabetes control. So, and then moving on, lots of medications. As you can see, this is gaining more real estate in the drug market, and the attempt to try and control diabetes and obesity, as there is a direct tie into these things. Scan through here, see if there's something else you see that's familiar, like Farxiga. That's a new one. Jardiance. These SGLT2 inhibitors, they also are proving to reduce cardiac dysfunction. So they're being advertised as such as well. The second bullet kind of emphasizes that. So these are heart and kidney problems, and these can affect that. So they work well on that. So for sulfonylureas, you'll hear that on commercials. Don't take it if you're on a sulfonylurea. So some of these medications don't work together. But I'm trying to see if there's anyone on there that is no, but these are your much older drugs as well. Okay, and then there's some less commonly used ones. I won't cover those too much, but I wanted to make sure you had all of those available to you as well. Okay, and then those who have a hard time controlling their blood sugars, combination therapy of using more than one medication, whether it's insulin, an oral medication, maybe that weekly injection along with it. These things all play hand in hand. Okay, here's a little bit of A&P for you. Absorbing that sugar through our gut. The average American citizen drinks about 90% of the sugar that they intake. Matter of fact, the U.S. government has a sugar tax for added sugars. That's why you like to see all those products that say no added sugar. Here's applesauce. Apples are straight up sugar, but it'll say applesauce with no added sugar because foods containing added sugars pay an extra tax per ounce of sugar that is added to those drinks. So if you ever wondered why your Coke, Pepsi products have skyrocketed, that sugar tax might be part of it. Okay, and then pancreas, impairs secretion, and then the liver production, the glucose production from the liver that goes into the bloodstream. So when you eat, you're absorbing that sugar through your GI tract, and then it goes in and gets filtered into the liver. One of those functions of the liver is going to be that secretion of glucose. So some of the medications that were listed up before, they inhibit the amount of sugar that the liver actually puts out into the system. So if you have impaired insulin function, if I reduce the amount of sugar that your body is actually getting into the bloodstream, you then have you can then have the input right there, right? You can have that going in there, and then some muscle actually will stimulate this glucose uptake into the cell. So it that's why exercise has a direct impact on that insulin management and sugar control. All right. Um, this is that one between. So it's not type 2, it is a type 1. This is autoimmune. All right. And they are now they're lessening the amount that they are calling type 1 diabetes as juvenile onset diabetes. And that is because they're realizing that these type 2 diabetics that have this insulin dependency are now being, that they are actually a type 1 that was late onset. So, risk factors. So, type 1 in LATA is starting, they're saying 30 years of age and younger, family and genetic issues. Of course, all disease processes are prejudiced against everything, so therefore, your ethnic groups and things of that nature. So, people with strange diets that have high fats, high sugars, they tend to have more of that. Your lower economic demographics, they have more access to all the bad things versus the good stuff. So they have a higher onset because they're also more disposed to the obesity and things of that nature. So hence you see that we have the triglycerides and your HDLs, right? History of gestational diabetes or babies over 9 pounds. So you might have undiagnosed gestational diabetes. I feel like I've dealt with this already within my own family, and this can lead to a lot of later problems like insulin resistant fat and things that will hinder your ability to lose weight or manage your weight. So there is that as well, even though you don't carry on the type 2 diabetes afterwards. Okay, clinical manifestations. All right, so hyperglycemia, the 3 Ps, right? You're peeing a lot, drinking a lot, eating a lot. Polyuria, dyspepsia, and aphasia. All right. You may want to pay attention to the manifestation of the fatigue, the vision changes, the numbness and tingling, reoccurring infections, which my face is covering the word here, and then which I can't seem to move that picture, so my apologies. I think I put it on another slide for you as well, because you'll probably see that again. So type 1, type 1s might have that sudden weight loss because they're not having they're not producing that insulin, but they are burning through their energy. And they could have abdominal pains and vomiting. So diagnostic findings: a person who has a fasting glucose of 126 or greater, right? I just need to gain some more weight. I might fall into this category one day. And then you have your casual, so less than 200. That means it doesn't matter if you ate something or whatever. Within about 15 minutes, your pancreas starts kicking out that insulin, and breaking down that sugar. So exceeding that 200, and then there's a chart in your book. Let me know in the comments, right? Like this was a YouTube thing, right? Let me know in the comments if you find that chart reference is wrong. I'd appreciate it. Okay, urine testing for glucose is the most effective method of diagnosing diabetes in older adults. That is false. The tolerance test is a better use of that. And you should not find glucose in your urine. That's a bad sign. All right. So our management, we want you to normalize these things. So when people get diagnosed with diabetes, they typically are managing with a sugar of like 250 or higher. And I know a guy, he went and he was just at a dinner with some friends and stuff, and one of the friends broke out a glucometer to check their blood sugar, and he was like, ooh, check mine, and his sugar came back like 465, and he was like, that's not good. And they tried it one more time. He was like, nope, that's right. And that's how he found out he was a type 2 diabetic. So we want to get those sugars down less than 150, although 70 to 100 is normal. 70 and less we want to treat for in a clinical environment as being hypoglycemic, although that's debatable. And then greater than 150 we want to treat to allow for digestion, because people snack here and there and it kind of messes with blood sugar, obtaining blood sugars that are accurate. Okay, our 5 components of management. So diet, exercise, monitoring it, and then our oral medications and injections, and then education. Man, there is so much that you can teach patients about diabetes in this one of those disease processes that's worth knowing. Okay. Management goals, again, diet, controlling what we put in our mouth, and how many times we're going to the fridge. That helps. Watching that blood sugar, taking those medications as we're supposed to, going back to the doctor when things aren't being run right. Okay, one of the reasons most people do not go back to the doctor is because they are they don't want to have to pay for more medications. They don't want to have to miss work, things of that note. So there's that one. Let me see. And reinforcing that they understand, have them teach this back to you. Okay? Have them read back to you what you said, like restate it back to you so they can show some understanding. All right, so meal planning. Teach them to read a food label. Oh my gosh, it's amazing how many people don't understand the food labels. So if you can give a demonstration of that, like the milk carton, the back of a soda can, things of that nature. All right, because they should be tracking on 50% of our carbs, 20% fats, and then non-animal proteins. Non-animal protein part, it's not a jive at being like vegan or vegetarian. It's just that animal fats are proven to increase our cardiac dysfunction and brain dysfunction. So when you add diabetes to it, you are now increasing those risks tremendously. All right. No, I'm not giving up bacon. Sorry. Okay. But I'm not quite in love with a cheeseburger yet. So, all right, glycemic index. Okay, so there is a food list. I don't have one here in this slide deck, but there is a food list of the glycemic index, and it shows like foods and things of that nature and where they fall onto that and how they break down and go into things. All right. Um, all right. So sorry I had to take a little pause there. So I'm gonna catch back up again. Um, so yeah, so when you're talking and educating your patients on eating, so like your raw and whole foods, um, they digest slower, so therefore don't um, they don't jump sugars up as high, right? Because once you cook something, it digests quicker. When it's chopped, there's more surface area, so it digests quicker. Pureed foods are like just liquefied, so of course they're going to be digested really quick. It's like mainline that sugar right to the blood. Okay, whereas, and then eating whole fruits rather than juices because of the fiber slowing it down. But understand this, you can't just go and like be a diabetic and go eat a whole banana. Um, we had a diabetic educator and she managed, she was testing out some of those CGMs, those constant glucose monitors, and um, it she had a banana and her sugars jumped up to like 350, like, and stayed there for a while. She's not diabetic. So, advise them, you're going to eat some fruit, maybe half a banana or half an apple, right? Um, okay. Alcohol, you know, your beers and wines are very high in sugars and carbs. Um, and then your brown liquors and stuff are based on, like, tequila. That's an agave. That's kind of like it's kind of like a sugar plant mixed with aloe or something. It's a weird looking plant. It's massive, but high in sugar. Rum high in sugar. Whiskeys, there's your corn and barley and wheats. Um, some vodkas are low carb, but uh, there we go there. Not encouraging, and I've already mentioned exercise lowering your blood sugar because you're burning that out through the muscle, forcing it to be used. Okay, and it also works on stress management and everything. So there we go. But with those precautions, you should have, if you're diabetic, you should have some kind of sugar with you. Um, to eat a snack because you could burn through your reserve quickly. Okay. So, and then they make it a point to state in here where if you are managing with diet and exercise and not on oral medications, you may not need that extra stuff. All right. Um, and of course, our elderly considerations with metabolism being slower. Insulin therapy, right? Um, this is something completely individualized, but it all has the same concept. You have a goal, you got to count carbs and do those type of things, and um, give yourself that insulin. So when we educate that, have them show you that they can give themselves an insulin shot. Some people can't bear to give themselves even the tiniest of needles, so they need to. It's something they have to learn to accept. Um, and then we have all of our insulins. So I remember seeing a commercial for Afrezza one time long ago. I love my medicine commercials. They tend to stay in my mind. But I've never seen an inhaled insulin before. So, or actually like the efficacy of it. Long acting, this is your Lantus. Okay, really no peak. It gets up there and hits a threshold and is long. And then by the time it should be coming down, you're giving yourself another shot. So that's your 24-hour. And then your rapid acting, your fast acting, your Humalogs and stuff. Those are there. Okay, regular insulin and NPHs have different half-lives on them. So, rapid acting, like 15 to 30 minutes, you start seeing an effect on blood sugars. Your short actings, it's like 2 to 4 hours, and then 4 to 6 hours, and then over 12 hours. So there is that. Preparations according to the time. Man, it's like, so you're a type 1 diabetic, you're going to eat. You kind of already know what your appetite is. You gauge what you're going to have. You give yourself some insulin, and you want to do this about 30 minutes before they eat. That's the education thing you want to do. You may see that again. It's a glorious purple. All right. So general approaches, we have conventional and intensive. General is going to be like for your type 2s and stuff. That's diet, exercise, maybe an oral medication. Okay, complications. So a local allergic reaction. This used to be huge, not as much of a thing anymore. The diabetes was initially treated with insulin that was pulled from pigs and cows, so your bovine and porcine insulins. And there is a 2 amino acid difference between those insulins and human insulins. So that's where your allergic reactions were coming into play. So people who had those, they would have a systemic allergic reaction, and sometimes they would have reactions at the injection site. So in the 90s, I didn't put down the exact date, so I apologize. They genetically modified a bacteria to produce as a byproduct human insulin. And now that is where all of our new insulins come from, is genetically modified bacteria that produce, basically they poop out insulin. They feed the bacteria poops out insulin, they strain it, collect the insulin, and bottle it up, and you're injecting it into people. And then that's how they, kind of like how people modify marijuana to make it stronger. Yeah, we modify insulin to make it more effective, so less does more. So when you're talking about those different types of insulins and things, I actually had the chance to meet a guy who was on the development team for that, and he told me about the FDA process and stuff that had to do with it. So it was very interesting. So these are some rare things. Are going to be hyperglycemia in the morning because you're not eating overnight, so there's no reason for you to have a spike. But that's a thing. And then your resistance to injected insulin. These people need a very heavy dose of insulin. These people are taking the very highly concentrated insulin pens and things to manage their insulin or their sugar levels. Okay, sub-Q shots, things you guys are doing on clinicals all the time. Insulin pens, these don't typically need to be refrigerated anymore. You change out your injector, you dial your dose, you press, it injects, and then you dispose of your needle end, and you are good to go. Then the jet injectors, there's that. Insulin pumps are Awesome. They have like a little slide gun, and you push it up against the skin, and when you slide it, the needle comes out, puts the catheter in your skin, and it gives you your insulin um, on a constant pump. So currently, if you have an insulin pump and a constant glucose monitoring device working hand in hand, you are then considered to have a artificial pancreas. They are looking to make a combined pump that's implantable, and then they can just give one injection into the pump and refill it. It'd be internal, so you don't have to change out catheters and anything like that. And I think you would have to, like, kind of like a pacemaker, replace they go in there and have to replace it like every 5 or 10 years. Very minor thing, same thing that like I said, like they would do with a pacemaker. That's going to be huge when that comes into play. The use and action of insulin. So these are our education points. We've already kind of talked about these. People who have a tendency to so the story I like to tell on this one about the hypoglycemia is the guy measured out. He knew exactly what he was going to order when he was going to the restaurant. He took his insulin. He's driving to the restaurant. He hits heavy traffic. He goes hypoglycemic and goes and has a massive vehicle accident. They thought he was drunk because of the altered mental status. Had he had some hard candy or a packet of sugar in his car and started feeling bad, he could have taken that, and it would have alleviated the need for him to the need for that to happen. So he didn't prepare himself for his trip after he took his insulin, in other words. And in hyperglycemia, it occurs over a longer period of time. This happens over days. So people with insulin pumps, when they fail to turn around and put the needle in right, and their readings are coming up high, a lot of times they don't know what's wrong with them because there's nothing wrong with them. The new needle that they had put in for the insulin pump did not go in right, so therefore they're not getting the insulin the way they should. So even though the machine is saying they need to, so sometimes you just gotta redo that, bite the bullet, replace that so that you're getting the insulin the way you should. If you're in a non-clinical environment and you have someone who has altered mental status and you're being the good citizen, you can always try for a little sugar, because a little sugar is not going to make that sugar any higher if they're hyperglycemic versus hypoglycemic. But it's a world of difference, and it's life-changing if you give them the sugar and they were low and it comes up. So keep that in mind. But we have to keep those things. We can't let them stay too high for too long. We'll go into that a little bit later and tell them what they need to do for that. Hypoglycemic, always keep a sugar, a candy, something on your person, in your pocket. So if you go hypoglycemic or you start feeling that way, you have something you can correct it with very quickly. And then as the hyperglycemia goes, that needs to be treated rapidly as well. So I know what to do with that, when to, ask about their habits and then make suggestions of what they should do if they're way off. Because again, the glucose monitors are cheap. It's the actual lancets and the strips and the things to do that are expensive. So people will try to reduce them, how much they're doing just based on that. Have them show you that insulin shot, and then how to use their insulin pump. So which one of these is rapid acting? Do, 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 do. Regular insulin is regular insulin. NPH is NPH. Glargine is your Lantus long-acting, and Aspart is your Humalog. So we're going to go with Aspart. That's your Lispro Humalog Leucine. Okay. Oral anti-diabetic agents, man, there are a ton of these, as you saw in my medicine slides earlier. And these are your type 2 diabetic medications. And they can do a combination of these oral drugs to maintain it, but they have the possibility of going hypoglycemic. So for instance, let's say you're doing one that makes your body better use the insulin that it does produce, and then you're taking another one that turns around and has your liver secreting less glucose into the blood. Now you can become hypoglycemic, okay, because your intake didn't match what you were doing, okay. So that's kind of one of those where that could happen. So hypoglycemia is the thing. All right. Other potential side effects are going to be nausea, lack of appetite. Not necessarily what people are complaining about nowadays, but those two things: nausea, vomiting, abdominal pain, loss of appetite, which sucks if you have to eat something because of your medication, right? And again, we've seen this already. This is just a different aspect of like where your medications and things go. Understand that on my screen, this is very small during this recording, so I apologize. And I know I look kind of like a ghost in the shadow, realizing that this picture is just not doing me a lot of justice at this time. Okay. And these are the different ways that the drugs work if you're into that. Acute complications. All right, hypoglycemia, easy fix, get some sugar in them. All right, prolonged can turn around, put them in a diabetic coma, which is that that sugar is so low that body cannot function. All right, whereas DKA is the exact opposite. It is identified by diabetic ketones in the urine, right? So a urine test. Acidosis, so sugar being an acid, you have an increase in the sugar, so therefore you're going to become acidotic, which means you're going to have a pH of what? I know you all just turned around and said that out loud. I know it. pH is less than 7.35. Yep. Okay, and then we're going to treat that. And so I'm going to go ahead and compare a little bit with this hyperglycemic hyperosmolar syndrome, HHS. All right, so moving on down, we have, and that's going to come up here in a second, our hypoglycemia, less than 70, I've already covered that. Your sweating, tremors, you're tachycardic, you're nervous. These people can become combative, vocally offensive. The mentation changes are way out there. Memory lapses. A lot of these people will not remember what they did when they were hypoglycemic, and they may sound drunk, but they are not going to have the old wine smell or sugar juice smell on their breath because they don't have the sugar. But that low sugar, like I said, they can lose consciousness, they can have seizures, and they can also result in death. We're going to give them fast-acting carbohydrates. So if they can turn around and drink something, get them to turn around and drink something with sugar in it. No diet sodas, please. If you're in their house and you're looking for something, be aware that any kind of candies you find may also be diabetic and have fake sugar. So, gotta find the real sugar, okay? Or these glucose tabs. So, 3 or 4 of those, perfect. And then make them a peanut butter and jelly sandwich and give it to them, okay? Because these things are going to burn up fast, and we need to give them something that's going to sustain them. If they are unconscious, cannot swallow, we can give them glucagon. Okay, glucagon will turn around and knock sugar out of the cell, increasing their blood sugar. All right, and then the D50, dextrose 50%, 25 to 50. That's an amp of D50. Make sure that you have a valid IV line, that the IV is patent. Okay. Our DKA, so they do not have adequate insulin. They are sugars are super high. They're going to be acidotic, right? Their ABGs are going to look acidotic, all right? They will be dehydrated because they're peeing, and they're sweating because they're going to be hot and dry, right? Their sugars are going to be up. They're going to be hot and dry. They're going to be acidotic. You might even find glucose in their urine, and that's a bad sign. Okay. Their sugars don't have to be super high. 250 is not extremely high. The defining piece on this is going to be the ketones in their urine. Okay. When they're prolonged, they're going to have some altered status. They might have that sweet wine breath, but the ketoacidosis is part of that, and you'll have deep. Remember this: deep, rapid respirations. Okay, that's Kussmaul breaths. They're breathing very fast, very deep. Okay, I know I sound creepy when I did that, but that's all right. Y'all needed something to wake you up. All right, so and then ketone body, and you'll find it in the blood and the urine. Typically, it's just a urine test, and it'll say positive ketones. So this can affect our kidneys, right? Glucose molecules are big and they can damage kidneys. So we need to check our kidney function, right? So we're going to be checking on that creatinine and our BUN, which my face is covering over here, and then our hematocrit levels. So that'll be an increase if we're urinating a lot. So there is that. Okay, remember kidney function tests, creatinine and BUN. There we go. So our management. So these people are going to be dehydrated, and we're going to be rehydrating them with IV fluid. So this is going to be the first thing that happens when these people come into the ED with DKA. They're going to get an IV started, some blood drawn, a urine sample, and they're going to start a normal saline IV drip at maybe like 100 to 150 because they're trying to dilute some of that sugar to help bring it down. Okay. And then they will turn around and put on a continuous IV drip of insulin. Once those sugars drop, they'll change that over to a D5. A lot of times it's a half normal saline. And then it doesn't change back. So they can spike back up, but it won't change back because we're trying to get them down low and maintain some sugar because they're going to get them down low, and then you take them off the insulin, and now they're going to crash because they haven't eaten anything. So especially if their level of consciousness is altered, right? So the goal is to reverse this acidosis and then get those electrolytes right again. Okay. So we need to correct their electrolytes slowly, like over a 48-hour period. We're not trying to slam all these things in place, right? So let's get that right. So let's say given the opportunity to prioritize your patients, uh, what do you think would be the most important electrolyte replacement that could definitely affect something? So, what electrolyte do people with an impaired kidney issue? Because if you're DKA, you might suffer a minor kidney injury, an acute kidney injury, AKI. So, what's something if you were urinating a lot and you're having, so where water goes, sodium goes and potassium goes, okay? So what do you think? What do you think needs to be replaced, right? Okay. I think the clue is there on the board. Okay, so and these people are going to look acidotic. So given a set of ABGs, could you pick out the one that would be most related to a DKA patient? I know, like, why does he hate us so much? All right, HHS, right? Because hyperglycemic hyperosmolar syndrome is so hard to say. Okay, so this hyperglycemia, this type of hyperglycemia is just a lack of sufficient insulin. But it's different from DKA because it does not have ketones or very little. But most of the time it's like negligent. And they are going to be like over the top with their levels. So these need to get, there's an increased rate of mortality. They say high rate, it's like 20%. It's not extremely high rate, but that's high enough, right? Their sodium levels are going to go up super high. Their electrolytes are going to go because they're going through they are urinating a lot. They have a lot of output, so much that they're probably going to put a Foley in them, and then we're trying to rehydrate them. So we're trying to correct electrolytes, and we're trying to correct their hydration. Okay. And then we're looking for neurological changes. Okay. So that's this. The type of patient population that you get that is typically affected is going to be your middle-aged and older patients that either are type 2 diabetics or they are considered to be pre-diabetic, or it's a new onset diabetes and they're not managing their stuff. Okay. So they're going to get that insulin, they're going to get rehydrated, they're going to be eating as long as they're conscious and alert. Okay. And then they're going to be taught that they are now a diabetic and they need to manage this. The exact cause of this is not quite known. From what I was reading, like they can give it a reason, but it's not a consistent reason. So long-term complications, man, we have the three biggies: macro, micro, and neuro. All right. So think of your vascular changes, your large changes, the things that affect your kidneys, your heart, your brain, your vessels. That's your macro. Micro, start thinking smaller, the inside of those kidneys, the little pathways, right? And then another part of the micro is that neuropathic, and you start affecting the nerves. Sexual dysfunction, The neuropathies, numbness and tingling in the extremities, the toes, the feet, non-healing wounds, all those things. Those are your long-term complications. All right. And then here we go again, right? Gotta, y'all know how I just love to hate some feet, man. Can't do it. Don't do feet. Uncontrolled diabetes, right? Unhealing wounds, fatigue. You're tired. You don't have that sugar control, man. You're just not there. Your vision. So again, micro, your vision changes, and then sugar is great when it's where it belongs, but when it doesn't, it leaves you open to infections. Okay, so reoccurrent infections. And look, it's in beautiful purple. Remember that. Okay, so here we are towards the end. I got a couple more slides that are worth noting, and just because they are here. So diabetes leads to only microvascular. That just sounds like I'm setting you up for failure. We all know that's false. We have micro, macro, neuro. Okay, and then this one, I added these two slides in here because diabetes insipidus is not necessarily a diabetic thing, but it is. So this is an ADH issue, right? We don't make enough ADH, anti-diuretic hormone, and we are peeing like nobody's business, and this is directly associated with this. Okay, and you'll see an onset with babies and young children, and it's like they can pee for days. Or the kid that's always soaking their diaper, like for no reason. It's like, wow, they didn't even drink that much. Okay, when I learned about this, I thought back and I went, did my kids have diabetes insipidus when they were little? And I was like, no, they just drank a whole lot, and they would just little tiny bladders. They would just go, go, go. And um, ah, sorry. And then other things. So severe thirst. You're peeing more than 3 liters in a day. You're peeing at night. You're wetting the bed. It's very dilute, pale colored urine. And then we treat this with artificial ADH. Okay, and we give that. All right. Let me see. The artificial ADH is desmopressin. So, and they will get that every 12 to 24 hours. And if you watch the specific gravities, there'll be influx. So, all right.